Management of atypical hyperplasia, including atypical lobular hyperplasia, atypical ductal hyperplasia, and flat epithelial atypia. This is one of the educational breast surgery videos, and my name is Nell Weber. I am an intern here at the University of Colorado. Today, we will start our presentation with a case study. We have a 41-year-old premenopausal woman, G2P2, who presented with a screening detected calcifications on her left breast. This was her baseline screening mammogram. She had no history of breast biopsies or breast pathology in the past and had no breast symptoms. She had no history of breast or ovarian cancer in her family, no significant past medical history or past surgical history, and no alarming medications. Furthermore, her breast exam was non-significant. There was palpation only of post-biopsy changes seen in the 2 o'clock position. Here is her bilateral screening mammogram. As you can see, there is scattered fibroglandular density. There is questionable asymmetries in the right breast, and on the left breast, there are calcifications seen in the upper and outer quadrant of the medial breast. On her diagnostic mammogram, the right breast's concern of asymmetry was partially effaced or dispersed with compression, so that was no longer of concern. However, on the left breast, there were 2 groups of indeterminate calcifications that required a biopsy. As you can see, I have encircled one of those sites of calcifications, and that is where a biopsy was taken. So, what do we do if the stereotactic core needle biopsy shows atypical ductal hyperplasia? ADH is the proliferation of uniform epithelial cells with monomorphic round nuclei filling part of the involved duct or completely filling the ducts but measuring less than 2 millimeters or involving less than 2 ducts. It shares cytologic and architectural features of low-grade DCIS, but is of limited extent. You can see this represented in the histological images I have placed on this slide. ADH is usually diagnosed as a target lesion. That means that this pathology is associated with the concerning feature that we found on the mammogram. The most common presentation to find ADH is simply a screening detected calcifications. Typically, we do not have a mass found on physical exam. The standard of care is an excisional biopsy, and the reason for that is because the upgrade rate after excisional biopsy is 10 to 20% to DCIS. The risks for increasing the likelihood of upgrade revolves around the concept of how much of the lesion were we actually able to sample. So if you had a very large lesion and the volume of tissue sampled by the biopsy was small, or the number of biopsies taken was small, or if the gauge of your biopsy needle was small, then you didn't get a large percentage of that lesion, and you can't be sure that you don't have sampling error. So that's the main thing to think about when having risks increasing the likelihood of upgrade. What is an excisional biopsy and what is the goal? So it is an outpatient procedure. The goal is to obtain a histologic diagnosis of concerning features, typically calcifications, as to exclude possibility of associated malignant or pre-malignant lesions such as DCIS. We are trying to perform an excision of the lesion, but we do not need to obtain negative margins. This is diagnostic and not necessarily therapeutic. Non-palpable lesions can be localized using a wire, use of magnetized seeds or clips with a radio frequency emitter, or infrared radar, such as the Savvy Scout, which is what we use here at the University of Colorado. On the right, you can see a core needle biopsy and how that's simply a sample of the lesion. However, an excisional biopsy, we are attempting to excise the entirety of the lesion. Now, let us talk about what we would do if the stereotactic core needle biopsy resulted in calcifications associated with fibrocystic change with ALH. Atypical lobular hyperplasia, or ALH, is the proliferation of monomorphic, evenly spaced, adhesive cells filling but not expanding the involved lobule. This can also involve ducts. It shares cytologic and architectural features of LCIS, but is quantitatively lesser in extent. Unlike ADH, this is usually an incidental finding. The most common presentation, though, is also on a screening detected calcifications, and you do not typically see a mass on physical exam. The standard of care is that there is no excisional biopsy required. However, it is important to note that this would require radiology pathology concordance. What that means is after the radiologist first looks at an image, they give their report on what they think the most likely result is. But what they will do is add an addendum to that report after the pathology has resulted. If they feel as though this pathology doesn't quite make sense with what they saw on their imaging, they will report it to be discordant. And if that's the case, then you have to go forward with an excisional biopsy because you cannot assume that there wasn't a sampling error. Now, taking that out of the picture and assuming that we have radiology and pathology concordance, the reason why we don't go forward with an excisional biopsy is because the upgrade rate is very low. It's less than 3% to DCIS or invasive carcinoma. Now, let's discuss what one of these pathology findings means for the risk of future breast cancer in your patient. If you were to find ADH or ALH on your biopsy, that would mean that your patient has an increased risk of breast cancer in the future, specifically a relative risk 4 times that of the average woman. Now, how do we manage our patient that now has an increased risk of breast cancer in the future? We do active surveillance and chemo prevention. Active surveillance includes an interval history and physical every 6 to 12 months and an annual screening mammography. We have found that MRI results in increased biopsies without a strong benefit and therefore do not recommend them. There will be a video presentation in the future discussing imaging surveillance recommendations and what type of patients an MRI is indicated in. For chemo prevention, that simply means endocrine therapy. Most common examples being tamoxifen and anastrozole. We give these to patients 35 years or older that have a 10+ year life expectancy. Lastly, what would we do for our patient if the stereotactic core needle biopsy showed FEA? Flat epithelial atypia, or FEA, is native epithelia replaced by atypical enlarged terminal duct units lined by columnar cells. This is a newer terminology and has had a variety of other vocab associated with it in the past. Similarly to the other 2 pathologies we've discussed, the most common presentation is screening detected calcifications, where there is no mass on physical exam. The standard of care for pure FEA is that it does not require an excisional biopsy. However, similarly to ALH, it does require that radiology pathology concordance. If that is not seen, then you do have to go forward with an excisional biopsy. The upgrade rate to malignancy when FEA is found in isolation is rare. However, this upgrade rate to malignancy increases when found with ADH, ALH, and LCIS. This is upgraded up to 20 to 25 to 40%. Here we can see from one of the papers provided for our pre-rotation readings, the discussion of characteristics of patients that had FEA on their core needle biopsy that was then upgraded to malignancy. So these 4 patients all had other pathologies associated with them. And when you look to the table on the left, you can see that for the 24 patients that had pure FEA, none of them were upstaged to cancer. However, 2 that had ADH were upstaged, and the one with ALH and one with ALH and ADH was also upstaged. Now, let's discuss how this pertains to the ABSITE. So unfortunately, ABSITE may not be as up to date as current breast surgery research. I have heard from senior residents that the boards can be up to 5 years behind in research, and the ABSITE can be up to 7 to 10 years behind. As breast surgery is a rapidly progressing field, this can prove to create some challenges. Currently, both ADH and ALH are indications for excisional biopsy on the ABSITE. However, something that does coincide with what I spoke about today is that if there is radiology and pathology discordance, you do need to go forward with an excisional biopsy. This is something that I have seen in a couple of practice questions during my studies. You also want to lean towards an excisional biopsy if you have a patient in the question stem that's greater than 40 years old. Per TrueLearn questions, this does tend to be a less tested subject in breast surgery. And fortunately, we will have a variety of more videos coming that will review a multitude of other subjects in breast surgery that will certainly be very pertinent for the ABSITE. Below, I have provided my references for this presentation. Thank you.